My talk today is about proximal humeral fractures, options, and management. Outline, I will describe the anatomy and the classification on brief. I will describe how to investigate the problem and will make some classification and classify the lesion. And decision making include how to avoid complication, some tips and tricks on ORIF of fracture of the proximal humerus. So the anatomy of proximal humerus is a four-part: head, greater tuberosity, lesser tuberosity, and shaft, with neck shaft angle is about 130 degree. Humeral head had a retroversion from 9 to 40 degree, is average 20 degree. Establish of proper version is essential for stability and function outcome. This is a very nice study about the blood supply for the proximal humerus. It's about 24 cadaveric frozen shoulders, and you will find that 64 of blood supply of the proximal humerus come from posterior circumflex humeral artery. The mode of trauma, as we all know, it's full on the outstretched hand. The deforming force, the greater tuberosity, go with the supraspinatus and infraspinatus, posterior and medial superior. Lesser tuberosity pulled by the subscapularis medial, and shaft pulled by pectoralis major medial and anterior. Neer classification is one of the important classification of the fracture on the proximal humerus. He classifies a fracture into 1 part, 2 part, 3 part, 4 part, valgus impaction. Each 1 part means fracture line with displacement more than 1 centimeters and angulation about 45 degrees. This classification helps us with decision making for the fixation or arthroplasty. AO classification gave number of the proximal humerus 1 and 1, classify into A, B, C. A is extra-articular 2 parts, B is extra-articular 3 parts, C is articular is 4 parts. So when we see an X-ray, we need how to deal with these fractures. So first, we need to know what is the natural history of the fractures. What happens if we leave the fracture without treatment? So this table is a very good table for a function consequence of the malreduction or a natural history of the proximal humerus. So at the left here, this is the element of the fractures, this is the type of the fracture, and this is the function outcome. If the head is dislocated, it will end with loss of motion. If the head on varus, it will loss of abduction. Head valgus means central impaction. Head on extension, loss of forward flexion. If the head is avascular necrosis or collapse, loss of motion. Greater tuberosity superior displacement mean loss of abduction. Greater tuberosity posterior displacement mean loss of external rotation. Lesser tuberosity anterior displacement mean loss of internal rotation. Rotator cuff tear, loss of motion and pain. This is an important point. So this paper, this risk of avascular necrosis, this paper published by Hertel criteria, Hertel published it on 2004, and he described 3 items: the metaphyseal extension, the medial hinge, and the fracture through the anatomical neck. And the Hertel criteria found that when the metaphyseal extension less than 8 millimeter, medial hinge displaced more than 2 millimeters and functions through anatomical neck, it means that the risk of avascular necrosis it's reached 97%. So it's an important paper. As you see here, this is the metaphyseal extension. It's more than 9 millimeters. It's good function outcome. But here, metaphyseal extension is less than 8 millimeters. So it's bad outcome. This is the medial hinge non-displaced or displacement less than 2 millimeters, and this is the medial hinge more than 2 millimeters. So we need to know who is the patient, what is his baseline functional, and what is his desire from his shoulder, what is the expectation, and he is cooperative with the physiotherapy or not. So this paper published by Chad et al. On 2017 about the prediction of the mortality in elderly patients with fracture of the proximal humerus. And he found that increase the mortality with the high anesthesia scoring system and with low body mass index. And this is the table of the content. and he found that specialty who treated non-operatively with high ASA and low body mass index is high mortality, and low mortality was patient treated at the beginning as the outpatient and later on treated operatively. Any option of operative, arthroplasty or fixation. So, what is the option of the treatment? Non-operatively, or ORIF, open reduction internal fixation, or minimally invasive, arthroscopic suturing, or intermedullary Neer arthroplasty, or reverse the shoulder arthroplasty. Arthroscopic, I think it will be included on the following lectures by all my colleagues. So I will talk about all options except arthroscopic. So this is the pyramid of the management. Start with non-operatively, minimally invasive, augmented with ORIF or ORIF, and arthroplasty versus non-operative. So non-operative, what is the indication of non-operative? It's 1 part or 4 parts was minimal displace or displaced fractures with a high comorbidities, a low demand patient, low compliance, or poor bone quality. What is the protocol? Initial support and pain control and early rehabilitation. This is an important issue, early rehabilitation. So this is Neer protocol for rehabilitation is a 3 phases. And I will start physiotherapy after 3 weeks. It's my recommendation. And I think I have a lot of confusion about the time of start physiotherapy with conservative management. So functional outcome is about 75% are good to excellent result with start less than 21 days of the physiotherapy post-injury. Surgical treatment to consider when there is a mismatching between the patient expectation and the natural history. You have adult patient and his expectation to make a full range of motion. We cannot tell him that you can go conservative. So we will discuss him with the patient, the function outcome, and what is the expectation of his shoulder. So the indication is displaced, unstable, head split, dislocated or open fracture. And as we mentioned now, we have to discuss the natural history of non-operative fracture, displaced fracture with the patient, and also the complication. We don't need to end with this failure. So we'll also mention how to override this failure. So the ORIF strategy is a point. First, we have to reduce the dislocated head. And after that, reduce all fragment and restore neck shaft angle, reduce post-tuberosities. And now we will oppose the deforming force, support the comminuted section, and fix starting from good bone to bad bone. We have some pattern of the fractures. First is the valgus fractures, as we see here. We need to disimpact that fragment and elevate the head here. And after that, reduce post-tuberosity on the fragment and following with filling the defect by graft, fibular graft, autograft, allograft, and fix with this plate. As we see here, this is separate screws, one for the lesser tuberosity and one for greater tuberosity. Second was the varus. It's a very common fractures, and there is a word that you have not leave the OR with the patient on a varus reduction. So how to avoid varus reduction? First, we need to elevate the head, even by periosteal elevator or by putting K-wires and correct the varus. We need to restore this Shenton line or this curve between the posteromedial and the shaft. As we see here, this is a K-wire we use on the reduction. Help the periosteal elevator to maintain the Shenton line. Reduction, the scalker, and use the scalker screw is mandatory. Alternative, as we mentioned, if you have a big posteromedial defect and you cannot restore this fragment or restore this posteromedial calcus, you may put medial plate or use this fibular strut graft and use calcar screws and filling the screws. It's an important varus. Using IM nail, the central axis of the implant is improves the biomechanics of the fractures. This is advantage of the IM nail. Advantage also is a biological fixation and a small incision. But the disadvantage is on the 3-part or 4-part, you cannot do indirect reduction. It's very difficult. As a tenuous fixation is very weak fixation through the head. The IM nail. Hemiarthroplasty on a 4-part fracture or a comminuted fracture or fracture dislocation or high risk of avascular necrosis with good rotator cuff, we can do hemiarthroplasty. Reverse shoulder arthroplasty is the same. 4-part fracture, fracture dislocation, high incidence of avascular necrosis, but with massive rotator cuff tear or cuff tendinopathy. So the management, we need to know who is the patient, why we will fix him, and what is his expectation. And this is 2 tables which enumerates each fractures and each functional outcome. And if it go with the patient expectation, so we can go with non-operative management. And if no, you can go with operative. If the patient expectation mismatching the function outcome, so we will have to fix this patient. So our take-home message, we need to understand our patient, who is the patient and what is his expectation, what is his bone quality, recognize the fracture pattern and the deforming force, and choose optimal treatment based on the patient and fracture. And thank you.